Hello and welcome to this video lecture on disorders of the central and peripheral nervous systems and the neuromuscular junction. We're going to start off our discussion with a topic on traumatic brain injury, or TBIs as it's called. This injury occurs when we get some type of external force that is going to cause an alteration in brain function. It could be caused from MVAs, falls, or unintentional blunt trauma. And we can classify this as either being a primary TBI or secondary TBI. So when we say primary, it means that it occurs immediately at the onset of that brain injury. There's little that can really be done to reverse that process. It could be classified as focal, meaning that it's a localized injury that's affecting a specific area of the brain. And when it's closed, that means the skull is intact, but the brain is sustaining that localized damage. So a contusion or a hematoma would be an example of a closed focal injury. If it's open or a penetrating focal injury, that means the skull has been fractured or penetrated, and that can lead to direct injury of a specific brain region, such as a gunshot wound or a sharp object penetrating through the skull. When we have a diffuse TBI, that's when we have widespread damage across multiple brain areas rather than being in one specific region. So this typically happens when we have a acceleration-deceleration force, which is going to cause a shearing or a stretching of the neurons. An example of this that may be pretty easy to think of is a high-speed car crash, right? We have the acceleration and deceleration, but something you may not have thought of right away is someone that is having, or rather after the fact of having a cardiac arrest. And that is because we have a hypoxic ischemic injury, meaning the brain damage is due to oxygen deprivation. And we can also see this in people that have swelling and increased intracranial pressure that can affect multiple brain areas. Now, a secondary brain injury is when we have a development of further neurological damage and changes after a primary injury. So this can progress over days or weeks and can continue to cause changes for years. It typically will lead to progressive neurodegeneration, which increases the risk of chronic brain disorders. And so this, like we said, is going to take place over a prolonged period of time. It essentially, from the primary injury, will cause a delayed cascade of molecular, cellular, and systemic changes. And that's essentially how it can lead to things like encephalopathy, Alzheimer's disease, Parkinson's, or ALS. So let's go into a little bit more detail on each of these, starting with our closed brain injury again. So imagine a sudden jolt, a fall, a car accident, or a sports collision, and our brain is floating inside of our skull and becomes violently shaken. This is essentially that closed brain injury where our head is going to strike a surface or some type of moving object. You can kind of see that movement taking place in these images over here. Now, as our head is moving like this, the dura mater, that is our protective outer layer, and that's going to stay intact. So our brain tissues aren't exposed to the environment. Now, the location of that impact is going to be important. So that injury, it will happen directly beneath where that impact is. So if we, let's say, have a car accident and we hit our head against that airbag, or if the airbag didn't go off and we hit our head onto the dashboard or steering wheel, we will have a coup injury. So I know it has a P there, but it's pronounced coup. And so we might have injury to that frontal lobe that we hit against, let's say, our steering wheel or the dashboard. But when we have a counteract to that, so let's say our head hits forward and then we are going to have our neck extend and we end up having the brain bounce back and strike the opposite side of the skull, then it's called a contra-coup injury. Now, both of these can cause serious damage, causing things like contusions, meaning bruising of the brain, hematomas, which is blood pooling within the skull, or even hemorrhages, meaning internal bleeding within our brain tissue. And even though there's no visible wound, closed brain injuries are going to be life-threatening. So we'll start to see people with these injuries have symptoms like confusion, dizziness, loss of consciousness, and we need to act very quickly so that we can intervene and prevent long-term complications. And let's quickly define what we see pictured over here. When you have an epidural hematoma, that means we're having bleeding between the skull and the outer covering, which we know as the dura mater. Typically, it's when we're going to have a tear within an artery that could lead to rapid bleeding and pressure on our brain. With a subdural hematoma, we know sub means underneath, so this is going to be bleeding between the dura mater that we would have over here and the brain itself. And so that's typically caused by a vein tearing, and this is more of a slow bleeding and can develop within hours to weeks. And lastly, we have this intracerebral hematoma. We know intra means inside and cerebral is referring to the cerebrum. So this is literally bleeding inside of the brain tissue itself. And it can happen from trauma, a stroke, high blood pressure that can lead to swelling. You can kind of see that swelling developing over here, and of course, brain damage. So here we could see the differences between a closed head injury, what we just talked about, and an open head injury. We're going to see these when we have a opening within the skull and the dura break and exposes the brain to the environment. This makes the brain vulnerable to infection and severe damage, and our injuries can be focal, like we said, or diffuse, meaning focal meaning a specific area, diffuse meaning more widespread damage. And it's common in compound skull fractures and missile injuries like gunshot wounds. We can have also complications develop from these, including bleeding, swelling, infection, and long-term cognitive or motor defects. And our treatment, of course, is going to require emergency surgery and then rehab after that. So good ways to protect ourselves from these things is wearing helmets, seat belts, and taking other safety precautions depending what we're doing. And let's touch upon diffuse brain injury. This is also called diffuse axonal injury, or DAI, and it affects widespread areas of the brain, and it's a severe type of a TBI that is caused by that rapid acceleration and deceleration, or it could also be rotational forces. That's kind of what you're seeing over here that is causing a axonal shearing on our neurons. And so we can see these types of movements taking place in car crashes or falls. We can also still have that stretching of the nerve fibers, and it disrupts our brain communication. Now, a DAI is defined by a coma lasting between 6 and 24 hours, with the severity depending on how much force impacts the brainstem. And recovery is going to vary, and some may face long-term cognitive and motor impairments. So this kind of closes out our primary brain injury. Let's move on into secondary brain injuries. Now remember that a secondary brain injury is going to be damage that happens after the initial trauma. So this will be an indirect result of that primary injury and can develop from systemic and or cerebral processes. So when we think about the systemic factors, that could include things like hypotension, hypoxia, anemia, and carbon dioxide imbalances that worsen brain damage by limiting oxygen supply. And within the brain, we'll have inflammation, cerebral edema, and increased intracranial pressure and ischemia that will further disrupt function. If cerebral perfusion pressure drops too low, then our neurons are not able to generate ATP, and this can lead to rapid dysfunction. So our management of this is going to focus on preventing hypoxia and maintaining cerebral blood flow. Without the oxygen, our free radicals being there, excitatory amino acids, and inflammation, we are going to set the stage for a worsening injury that could develop into more of these neurological deficits that you see listed over here. So our secondary brain injury is a major factor, in acute brain trauma, making early intervention critical here. And now for our categories of TBIs. A mild TBI is typically called a concussion and may cause little to no loss in consciousness, brief confusion, and possible retrograde amnesia, where events just before the injury are going to be forgotten. In moderate TBI, this will involve a longer loss of consciousness, so somewhere in between 30 minutes to 6 hours, with confusion and memory loss lasting over 24 hours. And in a severe TBI, that means we have unconsciousness for more than 6 hours, and that often leads to long-term cognitive and neurological impairments. Now let's talk about some complications of TBIs. We can see these arise that can affect recovery of someone that has an injury like this. So we can develop post-concussion syndrome that can linger for weeks or months after a mild concussion, causing things like headaches, dizziness, and trouble concentrating, though symptoms usually will improve with time and observation. Another complication is post-traumatic seizures. That often appears within days of the injury and sometimes persists for years. So in order to reduce the risk of this, we want to do early seizure prevention, which is going to be crucial in moderate to severe TBIs. And the last complication we'll discuss is chronic traumatic encephalopathy, also known as CTE. And this is a progressive brain disease caused by repetitive head injuries. So you may have heard this being discussed a lot within football. So we do see it a lot in athletes, also military personnel, and workers that are exposed to head trauma over time. So maybe somebody that works in construction. Our symptoms develop years later and include things like violent behavior, loss of impulse control, depression, memory loss, and cognitive decline. And motor function can also deteriorate that affects daily life. And unfortunately, there is no cure, so prevention is going to be key here. You want to limit those repeated impacts and improve any type of protective measure that could reduce long-term damage. Now let's shift gears and talk about spinal cord injuries, and we can classify these as primary and secondary as well. So we'll start with our primary spinal cord injuries, and that happens at the moment of trauma, causing immediate tissue damage, and it can result from things like falls, accidents, or direct impact. And improper movement after the injury can, of course, make it worse. So our spinal cord injury can occur even without a fracture or dislocation, as we have extreme forces that can still damage the cord. And so having rapid immobilization is crucial to prevent further harm and improve our recovery outcomes. Now let's move into talking about secondary injuries, which you see pictured over here. And we're going to talk more about that on this next slide. These are injuries that are more of a chain reaction that starts after the initial trauma and can last for weeks. So these processes could include things like bleeding, swelling, inflammation, and a lack of oxygen, all of which can cause further nerve damage. And like we saw in that previous image over here where we're having damage and swelling taking place, if that swelling occurs in the cervical spine, it can be life-threatening and potentially affect breathing and heart function. Reason being is that that is very close to our brainstem, right? Where we have those cardiovascular and respiratory centers. And preventing inflammation and managing that swelling early is going to be critical to make sure that we reduce long-term complications. Let's talk about some vertebral injuries next. These are going to happen when the spine is forced into motion, whether it's acceleration, deceleration, or impact forces. And so we'll see with each of these injuries, it's going to vary as far as its severity. When we have a simple fracture, that means we have a single break within the bone. And when we have a compressed fracture, which you can see an example of that over here, this is also called a wedge fracture. It happens when the vertebra is going to collapse under pressure. In a comminuted fracture, also known as a burst fracture, will have that bone shatter into multiple pieces. If we have a dislocation, that will happen when the vertebrae move out of alignment, which can then put pressure on the spinal cord. And let's take a look at some of the other fractures that we have here. We'll start at the top over here where we have a hyperextension of the spine, and this can result in a fracture or non-fracture injury with spinal cord damage. So you can kind of see how when we have a increase in this curvature over here, we would have, it's called an anterior spinal ligament here, be stretched, and we're putting tension on these vertebral bodies over here. And so as that tension gets created, we are almost pinching and compressing that spinal cord there. Moving on down to this example here, you can see that the neck is flexed here. So flexion of the spine is the injury, or I should say hyperflexion really, which is producing a translation or subluxation of the vertebrae, and that compromises the central canal and compresses the spinal cord, parenchyma, and vascular structures. So we will have stretching of the ligaments in this region, and so that puts the compression on the tissue surrounding this area, as well as the veins and arteries that we're going to find within this area. Then we have our axial compression injury of the spine. This is when our spinal cord is going to be contused directly by retropulsion, meaning that this bruised area, when the bone is fragmented, or maybe sometimes the disc is also affected and it is being pushed backward. So you can kind of see how that is moving back into that spinal cord space, which of course could be a potential reason for nerve damage. And lastly, we have this example over here. This is a flexion rotation injury of the spine, where you can see some torsion is put on the vertebrae here, which is going to distort the space where the spinal cord is. Now, vertebral injuries happen when the spine is forced into motion, like we said, through acceleration, deceleration, or impact forces. And those injuries can lead to spinal cord trauma. And one of those manifestations of this trauma can be spinal shock, where normal spinal cord activity completely stops at and below the site of injury. And this happens because our brain signal can't get through. It's going to then have a sudden loss in reflexes, which are known as areflexia, and flaccid paralysis and no sensation. Other effects can include loss of bladder and bowel control, a drop in blood pressure, slowed heart rate, which you know as bradycardia, and also poor circulation. And as you could see from the image on the right-hand side here, this type of damage can occur at any level. And while some functions may return as the shock starts to resolve, the extent of recovery depends on the severity of the damage. So you can see the different terms here depending on where that level of injury is. Another manifestation of spinal cord trauma is neurogenic shock, and this is a life-threatening complication which can occur with injuries above the level of T6. So that is an important level to memorize for this. It happens when our sympathetic nervous system activity is lost, and that leaves only parasympathetic control, which can lead to things such as low blood pressure, slow heart rate, and poor circulation. And the last type of manifestation we're going to talk about here is another serious complication known as autonomic dysreflexia. And this can cause a sudden and extreme spike in blood pressure caused by a massive sympathetic response. And this happens when our sensory receptors below the injury are stimulated, but the brain can't send signals to stop it. So without quick treatment, this can lead to stroke or even death. Now, I didn't include our normal response pathway, but let me just walk through it really quick. We are going to see a visceral distension and pain receptors active, and it would basically send the impulses through our spinothalamic tracts to carry that into the brain. The brain would then interpret sensory inputs and decide what to do with that. So either we're going to empty our bladder or remove the painful stimulus, whatever it is. And that will basically target our motor cortex to send information down our corticospinal tract. So we're carrying these motor impulses down to the appropriate muscles in order to get that effect. So again, that is a normal response. Now, what's happening in this hyperreflexia is that we are going to get that initial change, right? Our spinothalamic tracts carry sensory impulses to the level of our lesion. So it's going to be T6 and since we have that lesion at T6, we'll start to get a reflex stimulus. So we're going to turn on that sympathetic nervous system, causing vasoconstriction, hypertension, pallor of the skin, and pilomotor spasms. So that is then going to lead to increased blood pressure and stimulating our carotid sinus. You can see that some of our cranial nerves are going to be put to work here. So our ninth cranial nerve, known as our glossopharyngeal nerve, that was stimulated by our carotid sinuses, are going to send a message over to our vasomotor center in the medulla, and the vagus nerve will be stimulated and head over to the SA node, which is going to result in a bradycardia, slowing of our heart rate. Then our autonomic response to the hypertension down to our level of the spinal cord lesion will lead to arterial dilation, flushed skin, headache, and sweating. Now let's move into degenerative disorders of the spine, starting with low back pain, which is a major health concern that's going to affect about 80% of people at some point in their lives. In most cases, the exact cause is unknown, which makes it idiopathic or nonspecific. And we categorize low back pain into two main types. Either acute low back pain, which is going to be sudden and typically lasts less than 6 weeks, and it can be accompanied by sciatica, which occurs when that sciatic nerve is compressed, which causes a radiating pain that goes down the leg. The other type is chronic low back pain, and this persists more than 3 months and can significantly impact daily life. There is a serious complication within this category known as Cotta-Aquinas syndrome. So if you remember, that was at the end of the spinal cord, the lower spinal nerves that move down and then of course exit out their specific spaces. And within the syndrome, which is pretty rare, but it can be very urgent, and the nerves become compressed within the low spine, which can lead to things like bowel and bladder dysfunction, leg weakness, and numbness in the saddle region, meaning the area of our body that would be in contact with the saddle when we're sitting on a horse. And so this is going to require medical attention so that we can prevent permanent damage from taking place. And degenerative disorders of the spine encompass a range of different conditions that are typically going to result from us just naturally aging, and often it is compounded by genetic factors. So we have this degenerative joint disease, which we call DJD, and degenerative disc disease, known as DDD. And these are among the most common, which are both going to have wear and tear on our spine's joints, and also the intervertebral discs. Remember, that sits in between the vertebral bodies. And these conditions can cause pain, stiffness, and reduce mobility. Another condition is spondylolysis, and this is more of a structural type of defect, or it could be a fracture in an area called the pars interarticularis. And this is a part of the vertebral arch. It's a narrow region that is really located between the superior and inferior articular processes and allows for movement of our spine. So it's really situated, if I'm trying to see which picture looks the best. I guess this one would be the one. It's kind of situated posterior to the pedicle. Remember, that's that foot part that extends out. And it's anterior to the lamina. I'm losing my mouse. The lamina, which is that thin plate right along in here. So right at that junction over there, and is approximately 1 centimeter wide. So not a huge space. And this defect can predispose somebody to getting spondylolisthesis, which is where the vertebrae is going to slip forward or anteriorly. You could see the different stages in which this can take place, really showing it here at L5. Causing a misalignment of our spine and potentially pinching nerves, which can lead to pain and weakness. Something else that could lead to pain is spinal stenosis, and this is when we have a narrowing of our spinal canal. This, of course, then can place pressure on our spinal nerves or the cord, and that can cause symptoms like leg pain and numbness, and in severe cases, sometimes a loss of motor function. And lastly, in this category, we have herniated intervertebral discs, which occurs when our soft gel-like center, known as the nucleus pulposus, is going to push and cause a tear of this outer layer known as the annulus fibrosus. And so this being displaced puts pressure on our nearby spinal nerves, and that could cause pain and neurological symptoms. Typically, these herniations are caused by trauma, degenerative disc disease, or a combination of both of these. And over time, our discs do start to lose water as we're aging, and that makes us less flexible and makes them more prone to injury. Even just minor movements could cause injury. And one of the major consequences of this is radiculopathy, where the herniated material is compressing the spinal nerve, which then, of course, is going to cause pain, tingling, numbness, and weakness. And this is also called paresthesia, where we're going to have it radiate down the affected nerve pathway. And we typically find this most commonly in the lumbar spine, which can lead to sciatica, but it can also happen within our cervical spine, which would then, of course, affect our arms and shoulders. So to treat this, we have conservative approaches like physical therapy and anti-inflammatory medications, and we can also offer more advanced interventions such as doing steroid injections or surgery if it is more severe. And all of these degenerative conditions that we just talked about are typically interconnected as people age, and they can become more pronounced, which then will affect their quality of life, unfortunately. Let's do this question here. A patient is told he has spondylolisthesis. Which of the following best describes the condition? Is it A, a spinal stenosis, B, radiculopathy, C, forward displacement of the vertebrae, or D, degenerative process of the vertebral column. If you said C, that is correct. We know that spondylolisthesis is a forward displacement of the deficient vertebrae. If you remember, spinal stenosis is where we had that narrowing of the spinal canal or cord that puts pressure on our spinal nerves or cord. Radiculopathy is where we have that spinal nerve root compression, and spondylolysis is the degenerative process of the vertebral column. Now let's shift gears and talk about cerebrovascular disease. That X should not be there. I'm going to correct that real quick. All right, there we go. So when we talk about CVDs, this is really referring to any abnormality in the brain caused by a problem within the blood vessels, and the most common neurological disorder, and will include a range of conditions that are going to affect blood flow to the brain. So our brain abnormalities are typically going to be due to ischemia. And that's when we're going to have a reduced blood flow that deprives our brain tissue of oxygen. And sometimes this will lead to an infarction. So think of these two terms as being separate and different. So infarction is referring to tissue death, whereas ischemia is referring to reduced blood flow, which of course can then lead to deprivation of oxygen. We can also have other cases in which we can have a hemorrhage where our blood vessel is going to rupture, causing bleeding around the brain. And other times, underlying blood vessel issues could include lesions, which refers to an abnormal growth or malformation within the blood vessel, while a blood vessel occlusion is referring to a blockage within that blood vessel, and a rupture, of course, refers to a burst or a tear within the blood vessel that could cause bleeding from the damaged area. And we can also have changes in blood quality, such as a clotting disorder or inflammation. And these factors are going to contribute to conditions like a stroke, where we need medical attention to prevent severe complications. So you, of course, have probably heard before that cerebrovascular disease is a major health concern. In fact, it's the leading cause of disability and ranks as the third leading cause of death in females and fifth in males in the US, that is. And a stroke is the most serious outcome of a CVD, and it's especially concerning because 25% of strokes are recurrent, which means we really need to focus on patient education for prevention. And our strokes can be classified into three main types that you see listed here. We have ischemic, which is due to a blockage within the artery and could be classified as either a thrombotic stroke from a local clot, or a embolic stroke from a clot that is traveling from another part of the body. The other type is going to be our hemorrhagic, which is due to a ruptured blood vessel. And then we have undetermined or cryptogenic, where there's no clear cause that's identified. And an ischemic stroke can occur when the blood flow to the brain is blocked, and it's mostly due to a clot. And the warning sign for this is a transient ischemic attack, or a TIA, which is a temporary ischemic event that's going to cause neurological dysfunction lasting less than an hour. While the symptoms will resolve, TIAs indicate that we are at high risk for a future stroke, and we don't want to ignore that, right? One major type of ischemic stroke is a thrombotic stroke, where we're going to have that blood clot that is stationary start forming in the arteries supplying the brain. and that gradually will narrow and fully block blood flow. And this often will result from atherosclerosis, which means that we really need to manage our risk factors such as high blood pressure and cholesterol to prevent that or reduce the severity of this decreased blood flow. And another type is going to be an embolic stroke that happens when a thrombus fragment is going to travel. So you could see that pictured over here where the plaque has moved, and we can have that travel along the bloodstream and block a small brain vessel. And that typically is going to originate from the heart or large arteries. Another type is going to be our lacunar strokes, and this results from an occlusion of a single deep perforating artery in the brain. These strokes are small but can cause significant neurological deficits and is often linked to chronic conditions like hypertension. And then we have hypoperfusion, and these are strokes that occur when we have a systemic blood flow drop, and that reduces oxygen supply to the brain and can be caused by heart failure, shock, or severe blood loss, and can require us to intervene immediately and try and restore circulation. As we mentioned before, we can have a cerebral infarction when an area of the brain loses blood supply due to vascular occlusion, depriving the brain of oxygen and nutrients. And this leads to a formation of a central core of irreversible ischemia and necrosis, meaning the affected brain cells are going to die. However, the surrounding area of this core is ischemic penumbra, which is an area of cells that are still at risk but potentially salvageable. And we could see this area over here at the blue. When we see the red is the area that's actually been infarcted. And so time is critical when we're dealing with something like this. We want to have a prompt infusion of thrombolytic agents like TPA, which stands for tissue plasminogen activator, which may help restore blood flow to the penumbra area and prevent further necrosis. So initially, the affected brain area becomes pale and softens, indicating that there's tissue damage. However, in some cases, an ischemic stroke can become hemorrhagic, meaning it'll have bleeding within the infarcted area. So I put these terms over here in the blue box to review their meanings. Ischemia means reduced blood flow, hypoxia is oxygen deprivation, and infarction occurs when blood flow is completely cut off, causing necrosis or permanent tissue death. More about a hemorrhagic stroke. This is going to occur when the bleeding happens within the brain tissue or in the subarachnoid or subdural spaces. The primary cause is typically hypertension, which starts to weaken the blood vessel walls and it makes them prone to rupture, like you see pictured over here. When this blood vessel bursts, we have a mass of blood that's going to accumulate, and it compresses the surrounding brain tissue. And so this can lead to ischemia, where oxygen supply is reduced. We get edema, this is swelling, and an increase in intracranial pressure. If it goes untreated, the combination of these factors can cause necrosis or permanent tissue death and worsening neurological damage. Next, we have intracranial aneurysms, and this is a dilation or ballooning of a cerebral blood vessel wall. And this could be because we have a weak spot on that vessel wall. And over time, if we have something like high blood pressure, it can push on that weak spot and cause it to balloon out or expand. And we have an increasing risk of a rupture or hemorrhagic stroke that is possible. We do classify aneurysms based on their shape. So we can have something that is more saccular or a berry aneurysm. These are small pouch-like bulges that typically form at arterial branch points. And then we have fusiform, or these are also called giant aneurysms. Just like the name says, these tend to be larger and involve the entire vessel wall and create a spindle shape dilation. So notice how they're a little bit more tapered at the end and wider in the center. And so early detection of this is going to be key. We can also see more of a saccular or berry type of aneurysm over here. And if we have enough pressure, this of course can rupture and lead to a life-threatening bleeding in the brain. Now on to our subarachnoid hemorrhages, also known as SAH, and this occurs when blood escapes from a damaged or weakened blood vessel into the subarachnoid space, which we know is the area between the brain and our meninges, so right below our delicate arachnoid mater. And this area is very dangerous to have bleeding within because it's going to increase our intracranial pressure that could lead to severe complications. Unfortunately, subarachnoid hemorrhages can reoccur, and it makes early detection really important and to manage it carefully. So clinically, we can identify this using two clinical signs that you see listed here. And I believe I have YouTube videos showing this done on a person, so you can really get the full animation of what it is. So we'll just start with the Brudzinski sign over here since we have it. And this is when we want to take someone and lay them in the supine position, so on their back. And we are going to have one hand behind the person's head and the other behind the chest to prevent rising. And if we see that the person is going to have their neck flexed and have flexion of the hip and the knee, then that is a positive indication that we may have a subarachnoid hemorrhage. And this is typically performed with our Kernig sign, which is when we have the individual supine again, and then we're going to have them flexed at the hip and at the knee, kind of making a 90-degree angle. And then we're going to slowly start to straighten that leg at the knee. And if there is pain or resistance or an inability to extend that knee, then we are going to see it as a hallmark sign of subarachnoid hemorrhage, indicating for us that there is some type of meningeal irritation. Next, let's talk about vascular malformations. These are rare and they're congenital abnormalities in the brain's blood vessels. One of the most significant types that we have is an arteriovenous malformation. That's what's pictured over here. And as you can see, it consists of a tangled mass of dilated vessels that are connecting arteries directly to veins, and it bypasses the normal capillary networks. So AVMs, as they're known as, AVM, is going to take place in any part of the brain, but usually we see it present at birth, and symptoms often appear later in life. These can include having headaches, seizures, or even hemorrhagic strokes if the malformation ruptures. So here's the second question for you. An extradural or epidural hematoma occurs. Which one do we think it is here? If you answered between the dura mater and the skull, you are correct. Moving on to primary headache syndromes. And to start us off in that category, we're going to talk about migraines, which are the most common episodic headache disorder that can last between 4 to 72 hours. They're more prevalent in women aged between 25 to 55 and result from a complex interaction of genetic and environmental factors. If we have a chronic migraine, it's going to occur more than 14 days per month. And of course, you can imagine that significantly impacts daily life. So to diagnose this, we want to include unilateral throbbing headaches that worsen with movement and is going to be moderate to severe and is accompanied by nausea, vomiting, photophobia, which is light sensitivity, or phonophobia, which is a sensitivity to sound. And we see that migraines progress through 4 phases. We have our premonitory phase, where early symptoms like fatigue or irritability will appear. The aura phase, which is going to include visual disturbances. The headache phase with intense throbbing pain. And the recovery phase, where the symptoms are gradually going to start to subside. As you can see, we have many triggers listed over here, and these can provoke a migraine and include things like disturbed sleep, skipping meals, overexertion, weather changes, stress, or even relaxation after stress. And there could be hormonal changes or fluctuations, particularly through the menstrual cycles, and excess sensory stimulation like bright lights or strong smells that can play a role within this. Lastly, we can have certain chemicals such as those in alcohol or processed foods like that contain nitrites that can contribute to this. Another type is going to be cluster headaches. These are severe unilateral headaches that involve the autonomic division of our trigeminal nerve, and they occur in clusters, hence its name. It lasts minutes to hours over several days, followed by long periods of remission. And these headaches primarily affect men aged 20 to 50 years old and are characterized by an intense pain that they have on one side of their head, which you can see pictured over here, and is accompanied by tearing or ptosis, which is drooping of the eyelid, and nasal congestion on that same side. In certain cases, we can have chronic cluster headaches where remissions are shorter or absent. Then we have tension type headaches, and these are the most common recurrent headaches. They're typically going to begin in the second decade of our lives, and they cause mild to moderate bilateral pain, often described like a tight band or pressure around the head. So you can kind of see that outline over here, and it may have a gradual onset. These headaches tend to occur in episodes that can last several hours to days. And if they're in more of a chronic form, then the headache is going to persist for at least 15 days per month for 3 months or more, which, as you can imagine, is going to affect your quality of life. So something that may help is managing stress or knowing your triggers so that you can reduce the frequency of this. Okay, moving into meningitis, and a lot of this we covered in microbiology, so hopefully this is a review, but meningitis is when we have an inflammation of our meninges that are supportive structures around the brain and our spinal cord, and it's often caused by an infection. It can be due to bacteria, viruses, fungi, parasites, or toxins, and can lead to more serious complications if it's not treated. We can also have meningitis present in different forms, such as acute, meaning it's going to develop really rapidly with some severe symptoms, subacute with a slower onset, and chronic, which means it's going to last for weeks or longer. Just a general view of what the symptoms would be, we would include a fever, headache, neck stiffness, and altered mental status. So let's dive into bacterial meningitis a little bit here. This is a serious infection that's going to affect our pia mater, the arachnoid villi, and since I have this pictured here, might as well point it out. So this is representing our dura mater, and in here is the arachnoid mater. And if you remember, the pia mater was the most intimate with the brain here. So that pia mater and then the arachnoid villi are these structures in here that are kind of projecting into our venous sinuses. And we also can include our subarachnoid space and our ventricular system. So I don't have a ventricle pictured here, but remember that they are those spaces within the brain that are filled with the cerebrospinal fluid. And so it's most commonly caused by meningococci bacteria and pneumococci bacteria, which can cross the blood-brain barrier and infect the meninges. So this infection can lead to infectious, meningeal, and neurological symptoms, such as a fever, stiff neck, and altered mental status. And then if not treated, we can have a rare but severe complication known as acute infectious purpura fulminans, which is a life-threatening condition involving widespread blood clotting and tissue damage. So rapid diagnosis and treatment are going to be critical to prevent serious complications and reduce mortality. Now for viral meningitis, which is also known as aseptic meningitis. And this is an infection limited to the meninges and is generally going to be less severe than bacterial meningitis. And it's going to be caused by either enteroviruses, arboviruses, and herpes simplex virus type 2, which can once again cross that blood-brain barrier and trigger inflammation. The symptoms are going to be similar to bacterial meningitis, but more mild. So it often will include a headache, fever, neck stiffness, and sensitivity to light. Now, unlike our bacterial meningitis, antibiotics are not going to be effective here, and treatment focuses on supportive care, with most cases resolving on their own within a few weeks. And lastly, we'll talk about fungal meningitis. So this is a rare but serious form of meningitis that'll develop slowly over time. It makes it a chronic condition because of this. And unlike bacterial or viral meningitis, we see with this fungal infection, it can trigger granulomatose inflammatory responses, which primarily affects the meninges at the base of the brain. And we see early symptoms can be subtle, but the first major signs often include dementia-like symptoms or communicating hydrocephalus, where we're going to get that excess cerebrospinal fluid building up in the brain. We can have immunocompromised individuals, such as those that have HIV or AIDS, at higher risk, and treatment typically will require a long-term antifungal therapy. A bit of a different type of inflammation within the head is called encephalitis. This is an acute inflammation of the brain and is typically caused by a viral infection. It can result from a mosquito, tick, or a fly bite, or from herpes simplex virus type 1, and in some cases it can develop as a complication of systemic viral illness. Now, the severity of this varies a lot. It can range from a mild infection with more flu-like type of symptoms to a life-threatening type of neurological disorder. And in severe cases, it can lead to things like seizures, confusion, loss of consciousness, which would definitely cause you to be concerned and have you go to the doctor in order to get an early diagnosis and treatment so that you can have the best outcomes. Over here on the left, you can see some of the different viruses and the cells that they are going to affect. Next, we're going to talk about the brain or spinal cord abscesses, which is referring to a localized collection of pus within the parenchyma due to infection. So when we have our immunosuppressed individuals, we'll see that they are at a higher risk as their bodies struggle to fight off these infections. And if we have a brain abscess, it can occur in different locations. So you can see how we have several of these throughout the brain tissue here. And we can also give them specific names, such as a epidural abscess or subdural abscess that we see pictured here, extradural abscess or intracerebral abscess, which is what's pictured over here. And if we have them develop around the spinal cord, we call them epidural abscesses because they're in that space, or intramedullary. And the symptoms of this depends on where the abscess is in location, but it could include fever, neurological deficits, and an increasing intracranial pressure. Now, when we have this abscess develop, we will see localized inflammation, which are pointed to in these red arrows, but over time it develops a necrotic core that is surrounded by a connective tissue capsule. And this process helps to contain the infection, but can also lead to pressure on the surrounding brain or spinal cord structures, which of course can cause neurological symptoms. If not properly treated, these existing abscesses can spread and form daughter abscesses in nearby tissues, which of course worsens this condition and can increase our risk of severe complications that would include seizures, paralysis, or even systemic infection. So I mentioned some of the clinical manifestations of these abscesses, and we also discussed how it depends on their location. So the earliest and most common symptom is going to be a headache. As this abscess grows, the symptoms will become more severe. So just to classify some of these manifestations we discussed, for a brain abscess, the patient will experience localized pain, fever, neck stiffness, and a purulent drainage from the nose or ears. With our spinal cord abscesses, this will often begin with some spinal aching, followed by severe nerve root pain, muscle spasms, restricted movement, and potentially weakness or paralysis. One major neurological complication of AIDS is an HIV-associated neurocognitive disorder. Also, the acronym for this is HAND, H-A-N-D. And that can include a spectrum of our cognitive impairments. So it can range from a mild neurocognitive disorder that can cause maybe some subtle memory and concentration issues to HIV-associated dementia, which is a more severe condition that will affect that person's daily functioning. Luckily, through combined antiretroviral therapy, or CART, it's been significantly reduced and has improved survival rates. Although despite this treatment, some individuals still experience cognitive decline, which calls upon making sure you're getting monitored and supportive care as needed. You may have heard of multiple sclerosis. I know we've mentioned it in our A&P courses before, and that is going to be a chronic progressive immune-mediated inflammatory disease that's going to affect our central nervous system and leads to multiple areas where we're going to start to lose the myelin sheaths and cause plaques, which will disrupt the nerve conduction and can result in neuron death and brain atrophy. Common symptoms in this condition will be paresthesia, meaning a numbness or tingling, are muscle weakness, impaired gait, visual disturbances, and urinary incontinence. We classify MS into 4 subtypes based on its clinical course, which ranges from relapsing, remitting to progressive forms. Unfortunately, there is no cure, but there are some treatments to help manage the symptoms or slow down the disease progression. We've also seen a lot of progress in implementing some physical activity and exercise. Next up, we have Guillain-Barré syndrome, or GBS, and this is an acquired inflammatory disorder that causes demyelination as well, but this time it is within our peripheral nerves, and this leads to progressive muscle weakness and paralysis. It often is going to begin with a tingling and weakness in the legs, which can advance to quadriplegia, respiratory failure, and autonomic instability, which affects the heart rate and blood pressure. Now, GBS typically develops after a respiratory or gastrointestinal infection, which means that there perhaps is an immune system overreaction that unfortunately attacks the nervous system. So although this is serious, a lot of patients recover fully within weeks to months, though they may experience some type of weakness or fatigue that lingers around. And here is a third question for you. Which of the following is true regarding multiple sclerosis? If you answered C, you are correct. And of course, this is within our central nervous system for multiple sclerosis. Now let's talk about some peripheral nervous system disorders. These are going to result from some type of injury to the peripheral nerves, which can be caused by disease, inflammation, or trauma. This disease can lead to neuropathy that affects nerve functioning and can cause symptoms such as pain, weakness, or loss of sensation. And the disorders are classified based on the number of nerves affected. So if we have a mononeuropathy that involves a single nerve, while multiple mononeuropathies affects 2 or more individual nerves. Our polyneuropathy refers to more of a generalized nerve damage, often seen in conditions like diabetes. And then we have our autonomic neuropathies that impact, of course, our autonomic nervous system, and that can lead to issues with blood pressure, digestion, and temperature regulation. Next, we have myasthenia gravis, and this is an acquired chronic autoimmune disease. It affects the nerve impulses that are being transmitted at our neuromuscular junction. So you could see that junction right over here, and then it's blown up. And unfortunately, our body produces antibodies, as we know them to be IgG, that are against the acetylcholine receptors. And so this prevents normal muscle activation and leads to muscle weakness and fatigue, particularly in the eyes and the throat, which can cause things like diplopia, which is double vision, difficulty chewing, talking, and swallowing. Now, serious complications include myasthenic crisis, which is a life-threatening condition where our respiratory muscles are going to become weakened, and that requires immediate intervention before it develops into respiratory failure. Or there's the case of cholinergic crisis that can occur due to excessive acetylcholine, leading to muscle overstimulation. Lastly, we'll discuss central nervous system tumors. And these can originate in the brain or spread from other parts of the body. Our primary brain tumors are known as gliomas, and they arise from the glial cells and include astrocytomas, oligodendrogliomas, glioblastoma, multiform, and the most aggressive type, which are ependymomas, which develop in the brain's ventricles. Extracerebral tumors can occur outside of the brain tissue, such as meningiomas, which are going to arise from the meninges, and nerve sheath tumors, which are seen in neurofibromatosis. And we can also have metastatic brain tumors that spread from cancers in other organs, such as the lungs or the breasts. And we have to discuss spinal cord tumors that could be classified based on their location. So we can have intramedullary tumors such as gliomas, including astrocytomas and ependymomas, which arise in the spinal cord itself. Our extramedullary tumors, like our peripheral nerve sheath tumors and meningiomas, develop outside of the spinal cord, but can still cause significant compression. And these tumors can lead to two key clinical syndromes. First, we have the compressive syndrome, which occurs when the tumor presses on the spinal cord. You can kind of see some of these tumors that would push on that spinal cord, which can cause weakness, sensory loss, or paralysis. And then we have irritative syndrome, which results from nerve root irritation, which can lead to pain, muscle spasms, or abnormal sensations.